Hi, I'm Sarah Dawkins, and I'm a nurse practitioner at Duke University Liver Clinic. So I see general and transplant hepatology patients. And today I'm talking about non-invasive testing for fibrosis. And this is a very hot topic and very important. So I hope that I can answer some of your questions and provide some clarity around, some people call them NITs, but non-invasive tests. So one of the first topics is just explaining the fundamental difference between simple steatosis or MASLD, metabolic dysfunction-associated steatotic liver disease, and MASH, which is metabolic dysfunction-associated steatohepatitis. And talking about why they're distinguishing between them is significant for patient management. So the biggest difference between MASLD and MASH is the presence of inflammation. So in MASH, it is associated with inflammation, hepatocyte injury, and there can also be fibrosis. MASLD, or kind of bland steatosis, lacks those inflammatory features and is usually more benign, while MASH, especially if there's fibrosis present, does have a higher risk of progression to cirrhosis, liver failure, liver cancer, and is also associated with greater liver-related and all-cause mortality. So non-invasive tests like serum biomarkers and imaging can help suggest the presence of steatohepatitis or fibrosis, but the differentiation between MASLD and MASH still relies on histopathology or biopsy because these non-invasive tests aren't yet fully validated to distinguish inflammation and ballooning with high specificity. So the non-invasive tests are really used for fibrosis rather than differentiating between MASLD and MASH. The next question is to compare and contrast the commonly used serum-based non-invasive tests versus the imaging-based tests in terms of accessibility and information provided. So the serum-based tests, like the FIB-4, the MASLD fibrosis score, even though now it should be called the MASLD fibrosis score, and ELF are best suited for initial broad risk stratification. They are easily accessible and they're cost-effective. While the imaging-based tests like FibroScan and MRI, they're more accurate, but they're a little bit harder to access, and MRI especially can be expensive. So you usually start with the serum-based testing first, and then move down to the imaging-based non-invasive testing if needed. So the advantages of the FIB-4, the MASLD fibrosis score, and the ELF for the enhanced liver fibrosis tests are they're inexpensive and they're widely available. FIB-4 just uses a CBC and your hepatic function panel, whereas the fibrosis score and the ELF test are send out. So based on availability or the clinic or the lab, those send outs may not be available, but most clinics can do a CBC and a HFP. So the FIB-4 is really where we like to start. They also have a really high negative predictive value. So they do not suggest advanced fibrosis. Chances are they do not have advanced fibrosis. So very high negative predictive value. And like I said, the FIB-4 is just very easily integrated in the clinic's primary care endocrine workflows. At Duke, we had a dot phrase. So it can pull most recent labs right into the chart and get that fibrosis, the FIB-4 assessment. The limitations of the serum-based test is they cannot assess steatosis or inflammation. So if you're trying to distinguish between MASLD and MASH, these are not the ways to do that. Unfortunately, histology is needed to definitively make that differentiation. And it also has limited sensitivity for early fibrosis. So it does great at excluding fibrosis, but kind of a gray area whenever there's early fibrosis formation. And then sometimes it will often yield indeterminate results for older patients or with patients with comorbidities such as a hematologic condition that affects your platelets that will automatically affect your FIB-4 score. The FIB-4 is not validated in patients over 65. So if it's a patient over 65, I usually start with an ELF test because of the age. And also the FIB-4 is not validated in younger adults. So neither is the MASLD fibrosis score. Or MASLD fibrosis assessment. So those are not validated in younger adults either. So that may lead to false negatives and underestimate fibrosis. So don't use those for less than 35 years old. The other limitation is that patients have acute inflammation or thrombocytopenia, like I mentioned, or other comorbidities. It can cause some false positives. So if patients have a non-liver related cause of an elevated AST or ALT level, or if they have like an infection or a hematologic disease that can affect the FIB-4 or the NFS test and give a false positive and say, oh, this patient actually has advanced fibrosis when they don't. So just taking that into account with those serum-based tests. So the imaging-based tests are the vibration-controlled transient elastography, or most people know it as FibroScan, and also magnetic resonance elastography, or MRE. The advantages are they directly measure liver stiffness, which correlates with the fibrosis stage. FibroScan is widely available and can also assess steatosis with the CAP, or the controlled attenuation parameter score. And then MRE, or MRI with elastography, is the most accurate. It's not affected by obesity. So the limitations with FibroScan, the accuracy for FibroScans is reduced in the obese population or inflammation. So the patient is drinking a significant amount of alcohol, that could overestimate fibrosis. Also, if they have congestion or any type like heart failure, that congestion can lead to a falsely elevated FibroScan score. Also, with like an acute hepatitis, that can also lead to an overestimation of fibrosis. So just taking that into account with the FibroScan. You still, even though we can determine how much steatosis is present with CAP, with the CAP score, it cannot distinguish between the MASH and the MASLD. Another limitation of MRI is it's usually more expensive and it's limited to specialty centers. And so not widely available in the community. Even at Duke, we have one location for elastography by MRI. So that does kind of limit the availability to use that. And then how do we integrate these results into the overall clinical picture to make informed management decisions about frequency or referral? So it's very important to use clinical context with these non-invasive tests. And this allows us to individualize care and also make risk-based decisions about their management. So for instance, high-risk patients, especially patients with type 2 diabetes, obesity, or multiple risk factors that are metabolic, should maybe be monitored more frequently, even if your liver tests are normal. So if you have type 2 diabetes, you should get a FIB-4 score, even if your liver tests are perfect, just because we know that patients with type 2 diabetes are more likely to progress to MASH or even cirrhosis. Also, if you have a patient who has elevated liver tests that don't really match the low risk test results you're doing, you always want to rule out any kind of other condition like an autoimmune hepatitis or a drug-induced liver injury or viral hepatitis. So you may need to refer to hepatology if it's just not fitting the picture, or if the liver tests are getting worse or just persistently staying elevated. And then the patient's history matters. So are they using alcohol? Has there been medication exposures? So you want to make sure that you're interpreting these non-invasive tests correctly and avoid false positives. So a patient who is recently discharged for an episode of severe alcohol-related hepatitis is not going to have an accurate FIB-4 score or even a FibroScan score immediately after, just due to the inflammation. The elevated liver tests and just the inflammation can cause that overestimation in fibrosis. And then the history, like I said earlier with the FIB-4, just making sure in an older adult or someone with a hematologic condition that could cause low platelets, that may not indicate fibrosis. It just may be a false positive. So getting a nut, if you're FIB-4 and then an older adult is indeterminate or high, definitely follow that up with another test. And then if things are not adding up, if your liver tests are elevated, if your patient's liver tests are elevated, the FIB-4 is elevated and things just don't add up, sometimes a liver biopsy is recommended. And so that's something that could be worked out with the hepatology referral. And of course, if patients at the non-invasive test shows advanced fibrosis, you definitely want to refer to hepatology. So that can be sorted out either with the FibroScan or MRI elastography. And if that confirms advanced fibrosis, they definitely need to be screened for HCC and varices, and then considering transplant or clinical trials. So with the monitoring frequency, low-risk patients should be reevaluated every 1 to 2 years. But if something changes with the clinical picture, maybe even more frequently. So using the stepwise approach really helps reduce unnecessary procedures. It prioritizes resources and ensures that our high-risk patients get timely intervention and evaluation. So how do I know what to do when my non-invasive test comes back? Who needs to have further testing? And who needs to see hepatology? So if your FIB-4 is less than 1.3, that is a low risk for fibrosis. So you can be monitored in primary care, and this needs to be repeated every 2+ years. If the FIB-4 is greater than 1.3, they're higher risk. So follow up with a FibroScan or possibly an ELF test. And then if the liver stiffness measurement of FibroScan is greater than 8, or the ELF score is greater than or equal to 9.8, I would refer to hepatology for evaluation. And then for MRI elastography, the cutoff for advanced fibrosis is at 3.5. So if you have an MRI elastography done and the MRI shows at 3.5 or greater, I would refer to hepatology. And then, of course, if the liver tests remain elevated, like I've said before, just making sure that you're evaluating for other causes of liver test abnormalities and doing a serologic evaluation. So that is what I have for non-invasive testing. I hope it helped. And if you have any questions, please feel free to reach out to me.